and get funding in our field of public health in the United States. So specifically, I'll be referring to the way that the CDC and also Healthy People 2020, as well as Public Health 3.0, how they conceptualize the social determinants of health approach. Also talk about what is the model, and then leave room for questions. Around 8:35, or actually probably a little bit later, you have to understand that all these times are approximate, but they're even more approximate now because of our tech glitches. But the first poll will appear, and that has to do with what you would expect your community's most powerful social determinants of health to be. And that's going to vary, I think, quite a bit across folks in this training, because we have, lots of Montanans, but we have lots of people from out of state as well. And within those two groups, we have folks in more rural and more or less rural settings. Having said that, most of my remarks today are geared toward understanding what challenges are in rural health settings, because that's, rural and frontier health settings are those that obtain here in the state of Montana. And so those are, many of the examples I'll share with you are sort of geared toward that kind of a setting. I have lots of examples from urban settings to share with you as well, but I do take a bit more of a rural perspective because of the state that I live in, and that the University of Montana Public Health Training Center is based in. So that first breakout room will should occur sometime before 9, and that will be your opportunity to have that first discussion.
Sorry, really quickly, can you maximize your presentation? Can you go into presentation mode for us?
Oh, sure.
Thank you.
There. Okay. All right, so I'm going to cut right to the chase here in our first section and just tell you what the social determinants of health model is to get us going. So, or what are the main areas that are considered under the social determinants of health approach. Those are economic stability, education, social and community context, health and healthcare, and the neighborhood and built environment. So those are the 5 sort of core areas that are considered as parts of or components of the social determinants that are understood to affect health and health outcomes in the United States today. So when we look at economic stability, that includes things like employment, food insecurity, housing instability, or other characteristics of housing and poverty. Under education, we have early childhood education development, and then higher education, high school graduation rates, and then acquisition of language and literacy skills. Social and community context includes things like civic participation and discrimination, incarceration rates, as well as social cohesion. And I have quite a bit of information to share with you on that social cohesion element, because I think it's a really great one to help us understand the perspective of the social determinants of health approach. Then we have, under health and healthcare, we have issues having to do with access, including access to primary care and also health literacy. And then last but not least, we have, as I've alluded in things I've said already, we have the neighborhood and built environment. And so that would include things like access to foods that support healthy eating patterns, rates of crime and violence, environmental conditions, and the quality of housing. So you can see here those 5 core areas. All right, so when we look at Public Health 3.0, we can see that there's been kind of an evolution since the 1800s in the way that we think about public health in across the world, but this is specific to the United States here. And you can see that later on in the schematic, so sort of towards the right on the continuum, the emergence of Public Health 3.0, which I think is the sort of governing rubric that we can understand to be influencing trends in our field today. And in the box, Public Health 3.0, you can see the emphasis on, number 1, engaging multiple sectors and community partners to generate a collective impact. And I'm going to be circling back to that on a number of occasions this morning, because that's such an important feature of doing or taking a social determinants of health approach. And then the second dot point is specifically having to do with improving the social determinants of health in the communities that we work in. And so we can also see that the social determinants approach is heavily emphasized within the Healthy People 2020 overarching rubric. And there are whole sections within their webpage that pertain to the social determinants of health. And I'm going to be returning to that later on, because I want to share with you some of the ways that you can govern your own thinking about program design, program implementation, and seeking funding for programs that you might initiate in your own community, and how to make that fit within the overlay that Healthy People 2020 and related organizations are using today. Okay, so when we think about rural contexts, we have to understand that there are some things that pertain to rural health that are a little bit different, obviously, from urban health. And so these dot points here help us understand some of those features that have been recognized by public health practitioners around the country as distinct challenges to rural settings. And these are many and probably familiar to everybody on the call, but do definitely focus our attention on the ways in which our work in rural settings can differ from urban settings. I especially wanted to emphasize the cultural, social differences that are in the final dot point on the right, because that is obviously one of the main foci of the social determinants approach. Okay, so let's pan out a little bit and put this in some kind of context in terms of what we do as public health practitioners. So this is sort of the background part. So where does the social determinants of health sit? Everybody on the call is probably familiar with what the mission of public health is, but I've brought those to your attention here, a couple definitions from the Institute of Medicine and the WHO here. I like the WHO's one. Public health aims to provide maximum benefit for the largest number of people. And some of the public health key terms that I'm going to be using today are clinical care, determinants of health, the differences between ongoing or chronic health care or health needs or disease processes versus epidemics or outbreaks, and then last but not least, health outcomes. So I put those up there for you guys to take a look at. Now, I also wanted to remind everybody that slides are available at the end of our conversation today, and all you have to do is just contact us and we will very happily share these with you. I wanted also to give a shout out to the CDC and the American Hospital Association, because I borrowed some of their graphics to share with you on this social determinants topic. If you look back over the history of the practice of public health, you can see that going back to 500 BCE, before Common Era, were the initial attempts at improving public health, going back to the Greeks and Romans. This carried, right on through across the ages. The first Public Health Act was enacted in 1848. That was in the UK. And in terms of sanitation, environmental health, we can see the role of the EPA emerging in the 1970s here in the United States. Obviously, public health has been very concerned with pandemics, from influenza to polio to HIV, and the control of those disease processes and helping people understand those disease processes in terms of what their own individual behavior is, in terms of the policy setting, in terms of the interventions that are made available to them that can affect their health outcomes. So when we think about the way that policy influences the enactment of public health initiatives, we can see these also going back right through history, back to biblical times, enacted through a variety of laws. Tobacco laws are one of the examples on the slide here, and also all kinds of public service announcements or public health initiatives associated with particular disease processes, such as in the slide here, I've included obesity. So the policy environment is obviously key, and and is influenced very much by what are the three core functions of public health. And those include assessment, policy development, and assurance. So you all are probably also familiar with the 10 essential services of public health, because I'm imagining that you're working on at least several of these every day that you're on the job. But oftentimes in my trainings, I have the opportunity to meet people who have only relatively recently joined the ranks of public health practitioners, having been at the bedside or doing other jobs in their life, and only sort of recently been promoted to their position as oftentimes as director, and not knowing exactly what public health even is, and doing a lot of learning on the job. So I think that's quite common in the trainings that I've run over the years. So one of the things that I like to include then is a reminder of what these 10 essential services of public health are. In addition to monitoring health, we also diagnose and investigate, we inform, educate, and empower, we mobilize community partnerships, we develop policies, enforce laws, link to and provide care, and assure a competent workforce, assisting people in reaching their health goals. And obviously we do a lot of evaluation and research as well. When you think about what the core functions look like at different government levels, it's easy to see in this example here, with this one here is with respect to tobacco programming or tobacco cessation. And you can see that the linkages between those three areas, assessment, policy development, and assurance, and across from federal, state to local, you can see the way that these things play together in order to help public health practitioners achieve specific goals, or ideally long-term to move the needle on health outcomes. In this case, as I said, relating to health outcomes or health behaviors, here relating to tobacco. So the reason that I bring these things up is because I think it's really important for us to understand that this social determinants of health model is one that has been embraced across levels of government in, I'd say, most states in the United States, and has also profoundly influenced the way that people are seeking funding, envisioning, or describing the program initiatives or the interventions that they'd like to enact, and also their ability to get funding for different programs that they're ready to roll out. And so all of these slides up until this point and remarks, I hope, give us a sort of a background that lays the groundwork for us to understand that this social determinants of health approach actually has a long history in public health. In more recent years, I think we've maybe gotten away from this holistic and multi-pronged way of thinking about health, and have the pendulum has sort of swung over to more selective approaches that focus on one particular health behavior or health outcome and one particular selective way of targeting that. However, as in health programming, whether you're talking about the global health space or whether you're talking about what's happening here in our own nation, the pendulum does swing back and forth. So now we're seeing the pendulum swing back to more holistic and multi-pronged approaches that are aimed at understanding how we can help improve people's health behaviors and health outcomes in a way that addresses all of the features of their lives, or as many of those features as is practical given the intervention in question, as possible. So when we talk about health determinants, I think it's really important to understand that the health determinants are many. Obviously, we have on at the top of the bullet points here, we have genes and biology. In addition to that, though, we have health behaviors, we have social or societal characteristics, and we have health services or medical care. Lots of different researchers and public health and clinical health oriented organizations have analyzed the relative strength of each of those determinants in shaping health outcomes. And what has been found over and over again in study after study is that while genes and biology play a role, it's a relatively small role, that health behaviors do play a role. Obviously, medical care plays a role, but the bulk of our health outcomes are determined by social and societal characteristics, which is also sometimes referred to as a total ecology of an individual or a total ecology of a community and health system within it. This health impact pyramid, I think, helps us understand some of the things that we just discussed. So in order to have a plan of attack or a means to effect change, we have to understand the way that things are linked together and have concrete and specific plans in order to knit those levels together with one another and to create linkages between them that are logical and cohesive. So we see here that this health pyramid situates the socioeconomic factors on the bottom. Above there, we get to making healthy decisions as a default. That is assisted by preventive medicine of different kinds, which is assisted by medical care when needed. And at the top of the pyramid, we have counseling and education. So you can see in the arrow on the right that as you move up this pyramid, we're increasing individual effort needed. And as we move down the pyramid on the left, we see increasing public health impact of initiatives or interventions that are focused at each of these levels on the pyramid. So then when we come to ways that interventions can work, again, I have a tobacco-related program example. And you can see here some of the examples that could, or some of the initiatives that could be associated with each of those different levels on the pyramid. So when we're thinking about socioeconomic factors and how they play into tobacco use, we have poverty reduction and education programs. Later in what I'm going to share with you today, I'm going to be rolling out some very specific and very clearly defined interventions that focus on that are initiated by people who are public health practitioners, but which are focused on poverty reduction and education. And I understand that might seem sort of outside of your wheelhouse as a public health practitioner, but I hope that the examples that I'll share with you, which are from the evidence-based supporting the social determinants of health approach, will empower you to think of ways that you, in your particular context or your particular setting, the population that you're working with, could see yourself initiating interventions that are similar in kind. So we have at the bottom initiatives or interventions that are focused on poverty reduction or education that targets socioeconomic factors. Above that, okay, so we have seatbelt laws in addition to smoking restrictions. Those are default healthy decisions that we can talk about. Preventive medicine, some things which would be included would be vaccinations or cholesterol screening. Medical care is treatment. I think everybody understands that well. And then counseling and education, getting back to the tobacco example, tobacco warning labels or initiatives that focus on counseling and educating people in manners that promote quitting. So you can see again how these things are arranged on the schematic with the arrows suggesting increasing public health impact as you move down and increasing individual effort needed as you move up. So I think that's always important to keep in mind, sort of the level at which the intervention is targeted and the way in which you should conceptualize the activity that you're doing and where in this pyramid it's focused. Who are the beneficiaries and where, which dial you're actually going to be moving the needle on. So having some clarity around that is absolutely essential. But that gets me a little bit into my program, wearing my program planning and evaluation hat, which is a whole other training that we offer through our Public Health Training Center, but which I hope many of you have already taken either from us or from another group. Okay, so this is a very famous schematic here. This is this figure on the left of your screen. And which shows on the little human being depicted the relative roles of each of these influencers on health outcomes. So at the bottom, we have 20% allocated to health care. In the middle, 30% allocated to health behaviors. Again, tobacco use comes up, but there are others as well. Obviously, diet and exercise, alcohol use and sexual activity are huge behavioral sort of buckets that influence our health outcomes down the line. One's physical environment is considered to contribute about 10% to health outcomes. And then the biggest bucket at the top are those socioeconomic factors. And again, this comes from a consideration of education, one's job status, attributes of the family, financial or household income, and social support networks. So we're going to do a pretty deep dive into each of those things in general in a few minutes, but also relating to specific interventions a little bit further and down the line in our considerations today. Okay, so over on the right, when we see the social determinants of health impact, we can see, again, about 20% of a person's health and well-being is considered to be related to access to care and quality of services. The other fully 80% is considered, or as studied, evidence has shown us, study after study, that the physical environment, the social determinants and behavioral factors are driving health outcomes from that sort of bucket of influencers. So we can also understand in more detail, we can, for each of those factors described above, we can also see that housing and specifics pertaining to housing, I'm going to give an example today having to do with radon exposure in housing and the linkages between radon exposure and education, educational attainment. We also see that food qualities of the diet, not just total caloric intake, but also type of food intake, obviously has a massive impact and varies enormously from one community to the next in the United States. We have transportation issues, we have violence, we have social support, we have employment and health behaviors. So when we talk about the social determinants of health, what we're talking about is these sort of 8 buckets within those areas that I described in an earlier slide. And you might not think that things like transportation have a big impact on whatever health behavior or disease process that is of interest to you or is works in tandem with some of the programs that you and your office are involved in. However, I wanted to share with you an example from my own work. I'm working together with folks across the state of Montana right now on a maternal health initiative with the Billings Clinic and folks at DPHHS, as well as here at the University of Montana. And when we started to look at what the primary causes of maternal mortality are, because the work that we're doing is mainly involved with trying to move the dial on some of the main contributors to maternal mortality. Lo and behold, it turns out that one of the main causes of mortality for pregnant women is automobile accidents. So that's an example of where these social determinants are interlocking in ways that can sometimes be unexpected. And I think that in the examples that I share with you today, you'll see the ways in which that can happen. So the other thing that I wanted to bring to your attention here in these sort of preliminary remarks, kind of situating and describing the model, is that there are some variations between groups in the way that they talk about what those social determinants are and the way that they organize them into their different component parts or the different buckets as I've referred to them. So this is another There are 6 areas. Those include economic stability, again, the neighborhood and physical environment, which we talked about before, education, food, community and social context, and then the healthcare system. So these bullet points underneath each of these 6 areas are a little bit different from what I shared with you before. Again, like I said earlier, some of the information that I'm sharing with you comes from CDC, and some comes from Healthy People 2020, and some comes from the American Hospital Association. This particular graphic comes from the American Hospital Association, and so you can see that the language can vary from one kind of set of one rubric to the next. But the gist of each of them is the same. And generally speaking, although the core areas or core components or those main sort of buckets can be labeled a little bit differently, generally speaking, what's under them is basically the same. What I liked about this graphic is that it further helps us understand some of the things that these 6 core areas can impact, and that would be those health outcomes in gray below, including mortality, life expectancy, healthcare expenditures, and then of course health status, and last, functional limitations. Okay, so I'm going to pause now, and we're going to run our first poll and then break out into our discussion rooms. And Emily and Alexis, my very capable assistants, are going to help with sorting you guys into discussion rooms so that you can have a conversation amongst yourselves about the way that you responded to this first poll, and what were some of the things that informed your thinking. So the first poll has to do with what would you expect your communities, the poll appeared in front of my poll question here, so let me move that over. Yeah,
I was like,
thank you, Emily. Okay, so what would you expect your community's most powerful social determinants of health are? And we'll see how you guys vote on this, and how that might vary from one setting to the next. Then we are going to put you into your Zoom rooms, and the question for you to consider is going to be, what were your poll choices and why did you choose them? We'll take a little break after that, and people can get a cup of coffee or use the bathroom, what have you, and then we will reconvene at 9 o'clock. Or where are we up to on time? Oh, let's reconvene at 9:15. Does that sound good, Emily?
Yes, how would you like your breakout rooms? How many in each?
I'm going to do just a total of 2 breakout rooms so that we can keep the conversation after the breakout rooms occur a little bit more streamlined.
Okay, so we'll have 12 in each.
Yes, ma'am.
Cool.
Good. Yeah, last time we had 4 breakout rooms and there was too much to cover.
That's fair.
Thank you, ma'am.
So fill
okay.
out the poll, folks, and then you guys will see a little invite pop up for your breakout rooms.